As primary care providers, we are gatekeepers, and so I want to make sure that we all feel like we have a good handle on some of the genetics around female cancers and how we can be keeping an eye out for things that put women at higher risk for cancers in the primary care setting. So consider this. All cancer is genetic, but not all cancer is hereditary. So, cancer in and of itself is implying a gene mutation, right? Whereas hereditary is saying that that person was born with that mutation. So whether they're born with a mutation versus that mutation occurring over time in their life due to environmental factors or what have you, that's what we're talking about here when we're talking about hereditary cancers. Okay, so basically there's two ways to get cancer. So hereditary cancer, we know that for any given trait or gene, everybody has two copies, right? They got one from their parents and one from their mom and one from their dad. So for any given gene, they have two of them. So with hereditary cancers, the assumption is that somebody's born with a mutation in one of those genes. So then over time, if the other gene then becomes affected, then that's when cancer can easily develop. Whereas with sporadic cancers, and that's most cancers, about 90%, basically over time, both of the genes become impaired. So it's the difference between only needing to have one impaired versus needing to have both impaired before cancer would develop. So with hereditary cancer, just thinking about what would put people at a higher risk for having or developing one versus the other. Actually, let's look at sporadic cancers first. So with sporadic cancers, it's age appropriate. So a woman tells you in the clinic that her grandmother was diagnosed with breast cancer at age 70, and she has an aunt on the other side of the family who also was diagnosed with cancer, and she was age 59 at the time. So in both of those cases, that the cancer would be age appropriate, and breast cancer is a fairly common cancer. So with sporadic cancers, we understand that they arise from gene damage, whether that's dietary factors, environmental exposure, hormones, normal aging, and more often than not, we just never know, right? And then to compare that with hereditary cancers, it would be somebody in their family or the patient themselves being diagnosed with a cancer at a much earlier time than we would expect. So for breast cancer, we think of that as being less than age 40. With colon cancer, we think of that as being less than age 50. Caused by gene that's been changed and then passed down that way. So like we said in our earlier definition. So we're born with two genes, and if one of those is already affected, then it only takes that other gene being affected before we'd be at cancer. So, which is why it would show up at an earlier age, right? Because it, if you think about how long it takes for both genes to be affected versus just one gene, that would happen sooner. So we also see clustering of certain types of cancers in a family, and multiple family members affected on one side. And then with hereditary cancers, it's more likely to be rare cancers in family. For example, a male having breast cancer, that's a lot more likely to be hereditary, and it's a lot more uncommon for a male to have breast cancer. And then individuals with multiple primary cancers or multifocal or bilateral cancers, so having both ovaries diagnosed with ovarian cancer, or having breast cancer and ovarian cancer, that should perk you to feel a lot more suspicious for that being a hereditary cancer. Okay, so hereditary cancer syndromes. I've listed the most popular ones that you should at least be familiar enough where if you hear it in clinic, you go, ding, 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 this person's probably at an increased risk for several types of cancers. So a hereditary cancer syndrome is an inherited gene mutation that increases the risk for more than one type of cancer. So one of the big ones here is HNPCC, so hereditary non-polyposis colorectal cancer. And usually if somebody's reporting this in their family history, ideally they know what it is. As in, yeah, my dad had colon cancer, and then if that's the extent that they know, there's a decent chance it probably wasn't this one, as opposed to my dad had colon cancer. I forget what it's called, but it's that one that means I'm at increased risk too. Um, so not that all of our patients are coming in fully understanding their family history, but if they did have this in their family, that would be something to make sure that they are aware of for the rest of their lives. So if somebody has a gene mutation for this HPNCC, that puts them at a high risk for colon cancer, ovarian cancer, endometrial cancer, stomach cancer, small intestine cancer, and bile duct cancer. So the ones we're focusing in on there then are ovarian and endometrial. Those certainly, all of those we should be aware of if we're somebody's primary care provider. Next runner-up is Cowden syndrome. So Cowden syndrome, people who are actually presenting with this syndrome, they typically have distinct lesions that might look kind of scaly or patchy, kind of like eczema, or whiteheads or skin tags. So I don't expect you necessarily to be diagnosing Cowden syndrome so much as, again, being aware that if somebody has it, they're at increased risk for several types of cancers. And in this case, for Cowden syndrome, that's breast cancer, thyroid cancer, and endometrial cancer. All right, and next up, I feel like I am not feeling adventurous enough to take a shot at pronouncing these. But we'll say that the Peutz-Jeghers syndrome, and please never quote me on these pronunciations. So this typically, if somebody's presenting with this syndrome, you'll see multiple pigmented spots, like on their lips or on their inner cheeks, so kind of darker areas, little patches. But this syndrome would increase people for colon, breast, and pancreatic cancers. And then this last one here, again, I'm not feeling very adventurous, so I'll let you look at it. And then this is going to put somebody at an increased risk for breast cancer again, brain cancer, and sarcomas. So not to have perfectly memorized, but to really have those syndromes kind of ingrained in your head as, oh, this person's going to be at an increased risk for multiple kinds of cancers. And if I'm their primary care provider, I need to refresh myself on what that is and make sure that I'm getting them the cancer screening that's most appropriate for them. Or potentially refer them on to genetic counseling or an OB to make sure that the appropriate screening is done. But this is certainly within your scope as their primary care provider. Okay, so hereditary cancer syndromes. So we want to have a high suspicion up if somebody has an Ashkenazi Jewish heritage and breast cancer before the age of 60. So those two pieces together. And Ashkenazi Jewish heritage, honestly, that's linked with so many things that should just be ingrained in your head if somebody comes in reporting that as well. So worth researching that more. And then breast cancer of anybody less than 50, breast cancer in both breasts at any age, both breast and ovarian cancer, male breast cancer, ovarian or fallopian tube cancer at any age, more than one relative on the same side of the family with any of the following cancers. So these ones tend to have interlinkings. So you might see a lot of ovarian as well as breast cancer on one side of the family, for example. So, and then we're going to add to that prostate, pancreatic, melanomas, medullary thyroid cancers, and pheochromocytomas. So all of those have a high hereditary link to them. So let's talk about the BRCA1 and BRCA2 genes. So everybody has these genes, so we want to make sure that we're getting the wording right here. It's not that if somebody has the gene, they're at an increased risk for breast cancer. It's that if they have the gene and then it has some kind of an alteration to it such that it can't do what it needs to do, that's when we have an increased risk. So both of these, they're tumor suppressor genes that control cell division. So they're found on chromosome 17. And then if there is an alteration or a change to the gene, it makes it so that it's either turned off or can't function properly. So we know that breast changes are always occurring due to environmental factors, dietary factors, or what have you. And so mistakes can be made when cells divide, and our bodies need the functioning of these BRCA1 and BRCA2 genes to see when mistakes are happening and either trigger that cell to have apoptosis or cell death, or fix the mistakes that have been made. Okay, so if both copies of the gene are inactivated, the cell doesn't know when it's allowed to divide, and you start having uncontrollable growth, and that's ultimately what's going to lead to cancer. So they might be, this individual might be born with their BRCA1 altered, and then if the BRCA1 on their other chromosome is fine, then they're fine. But if over time alterations occur to that other set that they have for the BRCA1, then that's when when someone would have uncontrollable growth that could lead to cancer. Okay. Those last two bullet points I feel like I've already said a couple times, so that's there for your reference. So how much increased risk is there then here? So for breast cancer by age, so by age 40, 50, 60, 70, let's see what BRCA1, BRCA2, being of Ashkenazi descent versus the general population, how that impacts it. So by age 40, 19% of people with a BRCA1 mutation will be developing breast cancer versus 12% with BRCA2. By age 50, it's all the way up to 50% and 28%. And Ashkenazi women alone here, and then you think Ashkenazi plus having a BRCA1 or BRCA2, that would really increase it. General population by age 50 is about 2%. And then age 60, it's all the way up to 64 and 50%. And then age 70, 85%. So that's really high. And it evens out about here for BRCA1 versus BRCA2 mutations. So Ashkenazi Jews have a 1 in 40 risk of carrying a BRCA1 or BRCA2 mutation, so they're much more likely to carry a mutation. Than non-Ashkenazi Jews, it's about a 1 in 400 risk for carrying a mutation on one of those genes. So misconceptions about genetic testing. First off, genetic testing is not covered by insurance. If somebody has well-documented risk, then it usually is covered. That typically doesn't end up being a problem. Testing is complicated. Honestly, geneticists are really good at it, and it doesn't have to be that complicated. And then finally, testing will cause you to lose health insurance. So based on HIPAA, people can't be denied, and for that matter, they shouldn't even be able to find out. So this shouldn't be a concern as well. So demystifying these pieces can make sure that women who really are at increased risk and should see genetic counselors, that we're able to make that a smooth transition for them. So let's talk about BRCA testing. So they would go to a genetic counselor who would provide education around it. And then basically what happens, so let's say it's me. Say I'm one of 3 girls and 1 boy as far as my siblings go, and say that my mom gets breast cancer at age 38. Now all of us kids are wondering if we might be at increased risk and if there might be a hereditary link to what's happening here. So if we as a family were thinking we were wanting to go down this road, this is what we would do. So my mom would be the first one to be tested. So whoever actually is infected, they would be tested first. And say she's negative. If she's negative for BRCA1 and BRCA2, there's no point in the rest of us being tested. So that's kind of how that works. So generally speaking, for the first person to be tested, say it's my mom, that would cost about $3,000. And that's comprehensive. So looking at BRCA1 and BRCA2, and it's an in-depth analysis on both of those. So it's pretty comprehensive, right? And then say they do find something. Say they find a mutation on BRCA1. Then for me to be tested as the second runner-up, so if if the one person um, it is detected, then you would go to the offspring. And say it is a couple generations removed, say it was my grandma, it would make more sense to test my mother before me, because if my grandma's positive and my mother's negative, there's no point in going on to test me, right? Okay, so my mom is positive and the rest of us have decided to get tested. It'll cost quite a bit less, probably around $450, because they're not going to check for BRCA1 and BRCA2. Whatever it was they found with my mom, that's what they're going to look for in me. So say that I am positive, then that's going to impact how often I should be screened for breast cancer. I'm not going to be on the same track as everybody else is for routine screening, right? And then I should also be offered within that genetic counseling atmosphere potential preventative measures. And then that also gives me information for my offspring as well, right? On the flip side, if I'm negative for whatever my mother was tested for, then my risk for developing breast cancer is essentially going to be the same as the rest of the population. Great. Oh, I just added here though, if no identified mutation is found in the family, so say my mom's side just had a lot going on, multiple people with breast cancer, ovarian cancer, etc., and we did the testing and nothing was coming back, that doesn't mean that we know everything, right? So there might be something that we don't know to test for. That doesn't rule out that there isn't some kind of a hereditary risk or link. So then from there we would evaluate my risk based on history and empiric data. And lastly, I just want to stress that only those fully qualified to review these findings and counsel based on findings are going to be the people conducting this test. So we're the gatekeepers for helping pick up on who would benefit from potential testing, but we're not the ones ordering this lab. We would refer to genetic counseling, and then they would be the ones determining what tests should be ordered. What did it mean for that to say BRCA half? That's 1 or 2. So when we do testing, the outcomes can either be negative, a variant of uncertain significance, or positive. So with negative findings, like I mentioned on the last slide, basically that does provide some pretty good reassurance, while not entirely ruling out the possibility of hereditary breast cancers in the family. And then variant of uncertain significance. So this is saying that we see a change to the gene, but we really don't know whether or not that change would increase the risk for cancer. So we see a change, but we don't really know if that means anything or not. As opposed to a positive finding would be that we do see an alteration found on one of the genes. And anyone in the family who has that mutation is going to be at increased risk. So variants happen about 10% of the time. And typically when this testing is done, it takes about 4 to 6 weeks, unless it's expedited. So people generally have to wait quite a bit of time there. So pros and cons to testing. Obviously this could be a long forum post in and of itself, and I would love for you guys to be able to flesh it out more, though I don't have a post for you on this, so you're welcome. So pros, definitely want to know your risk. So that can be helpful, knowing the risk that you might pass on to your children. It can reduce anxiety associated with not knowing, and then it also gives you the opportunity to choose prevention options based upon your results. So that would be some of the pros. On the con side, we have cost, potential insurance issues, or fear of genetic discrimination. There isn't any evidence for this being a founded fear as far as, for example, insurance stopping coverage or whatnot, but that's definitely a fear for a lot of people. Adverse psychological effects, so that could be transmitter guilt, or survivor guilt, depression, anxiety, etc. Family rifts can sometimes happen too, like if one family member is tested and then all the other family members are wanting to know, but whoever it was that was tested doesn't necessarily feel like they want to open that up to the whole family. yet it's impacting potentially everybody one way or the other. So that there's some potential dynamics there. And ultimately, the results may not be informative. So it could be a variant finding, for example, where we're not quite sure what it means. So we set out to have some answers and then we didn't come up with any. Okay, so let's talk about what we would change if somebody did have BRCA1 or BRCA2, for example. So somebody's at particularly increased risk for breast cancer. And this could be somebody who decides they don't want to be tested, but who you just really feel like has quite an increased risk for cancer. Again, we're not talking I've got 2 family members and they were in their 70s, right? But legitly having risk factors that would cause you to pause and consider this to be hereditary. So breast cancer screening, mammography every year beginning at age 25 to 35, and particularly 10 years prior to whoever it was in their family who was diagnosed, who's in a direct line. So if my mom was diagnosed at 38, then I should consider starting testing at 28 for mammograms. Clinical breast exam every 6 months beginning at age 20. Monthly self-breast exams beginning by age 18, and I'm especially thinking about people where you know that they have a mutation on BRCA1 or BRCA2 because we saw how high their risk is. Okay, and then ovarian cancer screening. This hasn't been shown to be effective in large-scale clinical trials, so there's lots of things we think about that might help with detecting it. So you could do like a transvaginal ultrasound with color Doppler imaging, so you could see like if a tumor is making a bunch of veins, right, you would be able to detect that with color Doppler imaging. Or you could draw labs for CA125, and though that has a lot of high false positives. You could do a pelvic exam every 6 to 12 months starting at age 25 to 35. But again, none of that's really been found to be effective in large-scale clinical trials. So being smart about that, and then I would have no doubt that we might get new recommendations for that over the years. So staying fresh on that as primary care providers is important. All right, how about with, let's see, hereditary non-polyposis colorectal cancer. So HNPCC, the one that's linked with a bunch of stuff. So colorectal cancer screening should be a colonoscopy beginning at age 20 to 25 and repeating every 1 to 2 years. The risk is that high for developing cancer. And then endometrial cancer screening would be transvaginal ultrasounds or endometrial biopsy, starting at age 25 to 35 every year. Okay, and then possible prevention options. So prophylactic mastectomy does reduce the risk of breast cancer ultimately by 90%. So Angelina Jolie really was vocal about that she did this. She did a double mastectomy. So you'll see that sometimes in the media. And media oftentimes is what triggers women to come in asking good questions. So that's one you might hear. And then it decreases the death rate by about 81% in individuals with mutations. And then say they've had cancer once, and then they just decide to do a mastectomy, risk of a second cancer if breast tissue remains is about 60% by age 70. So then if we look at the reduction by age, if they do it before they're 40, then that's a 70% risk reduction. If they do it between 40 and 50, that's a 40% risk reduction. And then if we're already older than 50, honestly, it's not going to make much of a difference from what we can tell. Okay, and then prophylactic oophorectomy, so removing ovaries, that's going to reduce the risk of ovarian cancer down to about 2 to 5%. Now, it can arise in the peritoneum, so that's why it's not completely obliterated. And then this would be something worth recommending if someone is at a really high risk after childbearing is complete. So then chemo prevention, tamoxifen has been commonly cited for this purpose. So that actually reduces breast cancer by about 45% in high-risk women. We're unsure if that carries exactly over to our BRCA mutation women, but definitely say you have a woman with a BRCA mutation who's had cancer once and then starts on tamoxifen for preventing a second primary cancer from developing, then that is helpful by reducing their risk for cancer, again, by about 50 to 75%. So, in a nutshell, about a 50% risk reduction for those regularly taking tamoxifen. So naloxone is similar to that, and then birth control pills. Birth control pills may slightly increase the risk for breast cancer. So you think about if the breast cancer they have is particularly sensitive to those hormones that you're giving, then that could potentially increase a breast cancer risk. On the flip side, if women are using the pill for 6+ years, that can actually reduce their risk of ovarian cancer by about 60%. And it does some good if it's just 3 years as well, you can see there. So something to talk about pros and cons with, and to make sure that you're feeling fully educated on that as their primary care provider. Okay, so lastly, just to wrap up here, in a nutshell, any family with multiple individuals with the same cancer, very young onset cancers, or rare cancer types should be referred to a genetic specialist. So that is our role as gatekeepers. All right, have a good day.